Bore da, a croeso I gyfarfod Bwrdd Iechyd Prifysgol Cwm Taf Morgannwg. Hoffwn I estyn croeso canes I bawb sy'n gwylio heddiw. Good morning and welcome everybody to this meeting of the Cwm Taf Morgannwg University Health Board, and a very warm welcome to people who are hopefully joining in and watching us today in the community. You're very welcome indeed. So just to remind us all, because of the COVID-19 restrictions, this meeting, as a number of our other meetings, are being held in this virtual form, and we're broadcasting today's meeting live so that hopefully we can provide an opportunity for as many as wish to listen into the deliberations of the Health Board and to look at all the papers that we've got before us today. I just wanted to begin, colleagues, just by setting today's agenda in a little bit of context, because this is a very difficult meeting for us. We've only got really two substantive items on the agenda today, but they cover pretty much all of the challenges that we are facing in Cwm Taf Morgannwg and indeed across the entire health service. We know, of course, the direct impact of COVID, all of those families which have been affected by this cruel disease and will continue to be so, and also the non-direct impact, all of those services which have been affected in the health service whose capacity has been reduced because of the impact of COVID, and also the impact on our communities. We all know how significant those impacts have been and how they will continue to be, economically, socially, deprivation of liberty. And of course, the communities which, as always seems to be the case, those communities which are already suffering the most, suffer even more as a result of this. And I just also wanted to, colleagues, just to draw attention to the impact on our staff. We are now 7 plus months into this pandemic and no immediate prospects of it coming to an end. This is, for all of our staff, I think, a completely unprecedented situation. And people are weary and tested to the limit, really, by what they're having to put up with. And of course, they're not just workers, they're human beings. They are the parents of children, they are the children of their own parents, they are partners, all of those family pressures too that people go home to when they finish work with us. So I wanted particularly, before we start today's meeting, just to pay tribute, really, to the phenomenal resilience, dedication, resourcefulness and innovation of our staff, all of whom are trying new ways to mitigate the impact of this pandemic on the services we provide. And in that, I think, is a real hope for the future, because we are learning new and different ways of providing healthcare. But in the meantime, we've got a national fire break, a strategy which is clearly evidence-based, but we need now to wait and see what impact it's going to have. So today, I think we'll see in our papers and in our discussion, trying to strike a balance is going to be the major challenge facing us. A balance between dealing with the immediate challenges of COVID, but also the lost capacity caused by that, and also a focus, I think, on the community and the need to support people whose behaviour ultimately will determine the impact of this pandemic, and of course, finally, to keep our staff going throughout all of this. We will, colleagues, as we know, we will get through this. It'll be a very difficult time and very challenging. There is some glimmer of hope that a vaccine is now not too far away, and that shows us the way out of the situation, but we still have many months to go. So colleagues, that's the very somber and very difficult context in which we hold our discussions today. Can I then just welcome several people to the meeting. So first of all, welcome to Dr. Sarah Thomas, Consultant in Public Health, who's attending the meeting on behalf of Kelechi Noam. And Sarah will be presenting an update on the latest petition regarding the COVID-19 pandemic. Also, very warm welcome to Debbie Benyon, Deputy Nursing Director who's attending on behalf of Greg Dix. Warm welcome to Kathy Moss from the Community Health Council and Olive Francis, the Vice Chair, who is attending the meeting remotely. She's observing by the public live stream, I think. And warm welcome also to David Jenkins and John Murray, who are also tuning in. Apologies for absence. I've received apologies from Kieran Montague, from Greg Dix, Kelechi Noam, Georgina Galeckley and John Beecher from the Community Health Council. And before we proceed with the other items, there's just one announcement to make, which is a mixed announcement. I'm sure colleagues will appreciate. It's just been announced that Alan Laurie, our Chief Operating Officer, has decided to retire next year, round about the end of March, I think, Alan. We will, and colleagues will want to say many more things about your incredible service to the health service in this health board and elsewhere, and there will be opportunities, I'm sure, to do that on occasions during the next few months. So can I, colleagues, invite any declarations of interest? Do anybody have any interest they need to declare in relation to any items on the agenda? I'll just pause for a second to give a chance for people to say anything. No? Good, thank you very much. So as you know, colleagues, we are dividing our agendas at the moment into two parts. There's the consent agenda, and then the agenda of items for material discussion during the meeting. Everybody has had a chance, I think, to raise questions in relation to any item on the agenda, and the questions and the answers are now available to board members and will be in the public domain just as soon as we can put them out there, so members of the public too can look at those questions and the answers to them. Can I ask colleagues, are there any items on the consent agenda that you would wish to move to the main agenda for substantive discussion today? I'll just pause in case there are any items. Nobody's indicating, so thank you very much. I'm assuming therefore that the consent agenda meets with your approval, and that the items for noting and so on that are contained within that you are content with. We'll move therefore to the main agenda item. We've had the action log. Can I just ask colleagues, are there any items not on the action log that you wish to raise now? No? Okay, thanks. So I'm going to change slightly the order of the agenda, if I may. The two substantive items, we're going to take them in reverse order because colleagues have some urgent operational commitments which they need to be released for. So first of all, we're going to take the item on resetting the Cwmtaf Morgannwg operating framework for the final 2 quarters of this year. And I think, Claire, you're going to introduce the item, so I'll hand over to you. Thank you, Claire.
Thank you, Marcus. I think we're all very familiar now with quarterly planning. We have successfully developed and delivered our Q1 and our Q2 plans, and what we have in front of us today is the plan for the next 6 months. So a combined Q3 and 4 operating framework. We are, in developing this framework, responding to Welsh Government's Winter Protection Plan and the NHS requirements within that. And you will have noted within the paper in front of you today that the deadline for submission of that draft was Monday the 19th of October. Welsh Government recognised the position we were in terms of our outbreak across the health board and extended the deadline for our submission by 5 days. This allowed us to develop our modelling and planning in a way that was reflective of that outbreak position, but also we were able to take into account the likely impact of the fire break that we now see ourselves in. And to reassure members, we did submit to Welsh Government within that revised deadline. As ever, a plan is developed across the patch and with the input of many people and departments. And before I bring in my colleagues, Alan, Howland and Steve, to discuss their aspects of the plan in a little more detail, I just wanted to pick up 3 points really, and bring us back to the challenging times that we have had in the last 6 months, and that whilst we recognise that resetting Cwm Taf Morgannwg is not a short-term project, we have made progress through Q2 in the delivery of our plan, and I think it's important for all of our staff and our public just to pause for a moment to reflect on that before we then move into discussing our plans for the coming months. Over the last quarter, some of the highlights are drawn out in the paper that you have in front of you, but I just wanted to emphasise the scale of the work that has gone into establishing the TTP programme under the leadership of Professor Kelechi Nowum, and how successfully that is being run in partnership. Over Q2, we were able to re-establish all essential services across Cwm Taf Morgannwg. There's always more work that we can do in terms of access, but those services are running and available to our population. The ability to have real-time information and data-driven decisions, that expectation is now becoming the norm. This time last year, we would not have been taking decisions in such an informed way as we do now. Those decisions and that information is always caveated with assumptions and trying to understand the broader picture of what we were doing, but we do have much more information available to us at all levels of the organisation than we previously would have. We've managed to roll out virtual consultations for our population incredibly rapidly. I was only reflecting with a colleague this morning on the fact that when we entered into this pandemic and lockdowns back in March, this organisation didn't even have Skype as a platform to make any virtual contact. We now routinely run our board meetings and other important meetings across Teams, and we have this virtual consultation capability now widely available across the organisation. And then the final bit that I wanted to highlight was the introduction of our stepped model for staff wellbeing. The most important resource that we have available to us through all of this is our staff, and we must look to support them to the best of our abilities if we are to support our population, and we have taken great strides through Q2 in doing that. And I'm sure there are other aspects that I don't have the time to be able to pick out here today, but there is a vast amount of work that has been done, and we will need to build on that, and there is a lot more that we will be doing over the coming months and years as we begin to unpick and reset our organisation as a result of COVID, but I just wanted to pick out a few of those highlights. 2 further points as we look forward into the coming months and the winter months that we have ahead of us. The modelling upon which our plan is based is some of the more sophisticated that we've been able to deliver for our organisation. We are able and have been able to bring in the impacts of all of the competing demands that our services and resource have on them. So that's looking at the likely scenarios for COVID, that's looking at the workforce demands for the TTP programme. We've been able to factor in the recent unscheduled care and winter predictions. We've been able to look at our urgent elective demand and be able to factor in some of that wider regional change that we recognise is underway. For example, the opening in the coming weeks of the Grange University Hospital within the ABM, within the Aneurin Bevan Health Board. What all of that has done is give us a really good overview and wide picture of what is required of our services, and it has allowed us to make informed decisions on where we deploy our resources, people and money, and where we make sure that our priority areas have got the right focus. What that does is it has brought to light that those competing demands do mean that we have choices that we have to make, and those choices must always be balanced across and with the knowledge of the wider harms that COVID is bringing. In the paper that you have in front of you, there is a diagram which highlights the 4 quadrants of harm. And I would reassure the board that as we take decisions and in the framing of the plan that you have in front of you, as we seek approval of this plan, it is within the context of understanding and trying to evaluate and make a balanced decision against each one of those 4 harms. It's the challenge that we all have of balancing the important and the urgent. We understand the pressures that we have in front of us every day, and that though our colleagues on the front line are grappling with, but we also understand the demands and the harm that is developing within our communities from those patients and our residents who are concerned about presenting for a medical illness or for investigation or to ask for help because they are worried about the impacts. We need to do more to be able to encourage people to come forward when they wish to. We understand the wider impacts on people's mental health as a consequence of this. And so the plan that you have in front of you seeks to balance all of those needs and looks to make the decisions in that balanced quadrant of harm. The bit that I need to draw to the board's attention is the immediate consequences of that whilst we had set out on a course of looking to deliver all of our urgent waiting list activity so that we would have cleared a backlog of our urgent waiting list and been able to keep up with the continued demand, when we have looked across the breadth of our modelling and looked across the breadth of our competing demands, we have our plan as presented to you today, as you will see on page 9 of the paper, looks to stabilise our waiting list position for our urgent and cancer care. And this does mean that unfortunately there will be patients who are waiting for treatment much longer than they or we as a board would desire. And it's important that we make these decisions in approving the plan in the cold light of the decisions that we have to make. There is a lot of work that is being done and some assurance that we can give in terms of our ability to deliver that elective capacity in particular. And I'd like to ask Alan Laurie to come in at this point, who will be able to talk us through a little more around what is being undertaken by our integrated locality groups in terms of that delivery of our core elective capacity.
Thank you, Claire. I'll start off, I think, by just talking a little bit about a question that was raised at the beginning of the board meeting in relation to urgent cancer care and where we have been in terms of urgent cancer care over the course of the last 8 months. Since April, we have been able to maintain a level of cancer surgery on all of our district general hospital sites through our emergency theatres. And we have continued to provide cancer care for patients who don't require critical care after their operations through the Vale Hospital. So a considerable number of people who had who required surgery for cancer, breast surgery, gynecological, urological, thyroid, and so on and so forth, have actually been treated. So I think it's probably important that the board is cited, as it has been before, that we have maintained a level of cancer care. Since the late spring, and again, the board will recall that we have been developing what we've described as green islands on each of our 3 district general hospital sites, and also trying to improve the level of our productivity, both in the Vale Hospital and also in the Cardiff Bay Hospital. And we were doing well on that and managing to get into some of the larger cancer cases, including cases such as colorectal, whereby there are fairly significant lengths of stay after surgery within the hospital, and obviously need for critical care facilities. Recent events in relation to the COVID outbreaks that we've had on each of our 3 district general hospital sites has meant that we've had to continue to look carefully at what we can do. And clearly within the Royal Glamorgan 3 weeks ago, we had to take down our green island. We continue to provide services both on the POW and PCH sites during that period. It's fair to say in the Royal Glamorgan we have restarted our surgery through our green island there over the course of the last week. Turning particularly to PCH, as a result of the restricted access to the Royal Glamorgan over a 2-week period, pressure clearly in relation to capacity both in Princess of Wales and Prince Charles has meant that there's been some significant challenges in balancing up our unscheduled care demands, the emergency demands coming through, those coming through with COVID and non-COVID symptoms, together with those that are continuing to require elective care. And I think that goes right back to the conversation that Claire was leading in terms of some of the choices that are in front of us and the choices that we have to make on a day-to-day basis, operationally and clinically, most importantly around what we do. Within PCH, we have continued to run what we are calling our green pathway through the day surgery unit there, and in fact that will be moving up to a 7-day-a-week approach over the coming weeks. For some of the larger cases, including colorectal cases, they go through what we describe as our amber pathway, so through our main theatres. And as a result of the increased number of COVID cases and a number of positive COVID cases in and around the surgical area, a clinical decision was taken to take down 6 colorectal cases. That was a clinically led decision. It was the right thing to do. As a result of the need to think about that across the piece, there have been and there are agreements across all 3 sites that for patients that urgently require that care, we will look to make sure we facilitate that as best as possible across the 3 DGH sites. Discussions have been taking place over the course of the last week between surgeons in Prince Charles Hospital and the Royal Glamorgan in relation to a number of urgent colorectal cases, and they'll be going ahead in the Royal Glamorgan rather than PCH as a result of the restriction that we put in place there. So I think it just gives a little flavour, one little slice of some of the work that we're trying to do around that. Clearly, as Claire indicated, we do need to think radically around whether or not there are other ways in which we can expand our elective capacity. So the plan looks to stabilise that those waiting times and those elective surgery for those in categories 1 to 3. We need to clearly have another think in relation to what we need to progress in relation to those who are in the level 4 category, and work is ongoing around that, and also looking at experiences elsewhere in the UK where they're using nurse practitioners, therapists, etc. on orthopaedic lists to see whether we can do things. We have and are about to look on a pan-CTM basis at a clinical reference group looking at some of the more innovative ideas across the patches that we might be able to put in place within our theatre capacity, ensuring that we maximise the use of our theatre time and maximise the use of our green islands, maintaining what we've said we're going to do and seeing if we can go further than that, but recognising that is all caveated with making sure we control and manage our unscheduled care, making sure we don't lose beds out the system as a result of outbreaks, and trying to stay within the capacity plans that we have identified on page 8 of the paper. I think that's probably all I was going to say in relation to the elective programme right now, and be very happy to take questions on that if that's helpful.
Thanks very much, Alan. That is very helpful, and colleagues will be aware we've got almost 2 pages of questions and answers in the papers, which cover, I think, a number of the crucial issues. Alan, can I perhaps just, or Claire, I'm not quite sure who, one or other of you, just invite you to. I was pleased, but also slightly surprised to see the assumptions around what's going to happen to waiting lists over the next 6 months or so, because what the paper describes is, it seems to me, and correct me if I've got this wrong, is that we're intending to stabilise the situation, so no better but no worse. That seems to me to be quite that would be a significant achievement if we were able to do that, given that we're going into winter, given all the pressures that we're taught to know about and so on. Tell us about the risks. Would you involved in achieving that?
So, Marcus, perhaps if I describe to you some of the assumptions that we have built into that, and then Alan can maybe talk from an operational perspective about the challenges that presents. So what I will remind colleagues is we are talking about stabilising our urgent waiting lists. So we must remember that this is not the totality of the waiting list. This is those patients who would be categorised against the Royal College of Surgeons categories 1, 2 or 3. And the assumptions that we have built into the plan allow for, as we've previously described, are a likely scenario. They are not the worst case scenario, and they do give us some opportunity, small though it may be, for improvement. But they do rely on us having a winter that would be of a similar nature to previous years, so that we don't see a huge increase in flu at the same time as we have COVID-19. They have taken some account of the changed position of Neville Hall Hospital and the Grange opening, but again, those are assumptions. This is a new and uncharted territory, and understanding how our and South Powys and the North Gwent populations respond to that changes of services. You know, we can only put in broad assumptions, which the NHS system agree with, so they are not our assumptions alone, but we will need to test those and be continuously monitoring them. We have made assumptions around some of the investments we are making in winter schemes. So in partnership with local authorities, we are assuming that they will reap a reward for both the patient and for the impact on our hospital beds that will allow us. All of this is designed, apologies. Apologies, Chair. All of this is designed to give us the most opportunity to undertake elective care through our winter months. That includes use of the field hospital, that includes staffing assumptions that no doubt Howell will come into around seeking additional working hours from our staff. So it is no small undertaking to allow us to be able to achieve this. But what I would say to the board is it is a plan that does hang together, if that were to make sense, but it is based on a number, probably more assumptions than we would ever have had at this stage, because there are so many uncertainties and such complexity.
Thanks, Claire. That's very helpful. Alan, yes.
Yep, certainly. Claire and I are a double act. Claire says the things I'm thinking, so that's a good thing. Planning and operations working in symmetry. I probably what I didn't touch on when I was talking about the elective programme was the other side of the equation, which is that winter protection plan. So as a health board and across our region, we are going to be investing something upwards of £11 million in winter related activities to look to manage the winter with a range of schemes, teams and innovation that means that we are getting patients treated appropriately, either outside of hospital as much as we can do, and when requiring hospital treatment can be treated and then returned back to their place of normal residence as quickly as possible. So that £11 million ranges £7 million that are going to be going into each of the ILGs, looking at schemes around enhancing the emergency department, enhancing staffing levels, improving what we call our ambulatory care offer, care of the elderly consultants at the front door, surgical assessment units at the front door, Also looking at our mental health services and mental health crisis teams. £2 million going into the 3 local authorities in what is called the Discharge to Recovery and Assess programme, enhancing our home care capacity, enhancing care home capacity, enhancing the protections into care homes, increasing the amount of rapid response we can get from the local authority, sort of one-stop shop arrangements, maximising what we've got in terms of what we know works well around stay well at home. £500,000 going into the voluntary sector. So the voluntary sector came forward across the whole piece from Bavo, VAMT and Interlink in relation to a range of really good voluntary sector schemes which we know work in terms of repatriating people from hospital to home, keeping people in the home, befriending schemes, isolation schemes and loneliness schemes, and about £1.5 million into primary care, which includes the contact ahead services, includes money into urgent 24/7 primary care as a pilot in the Rhondda, money into urgent dental care, which will run through our dental teaching unit. And we know dental pain can result in attendance at A&E, can result in so on. So it's about, keeping people away from hospitals, but also making sure they get rapid care they need. And money into mental health services in primary care as well. And Claire referenced mental health and the needs for that mental health earlier on. So a very significant package, more than we've ever put more into our winter plan. The assumption being, if you do those things, that takes some pressure away from the front door, means that we manage within, and I hate to use the numbers, but you'll see those numbers on page 8, the 957s, 972s, making sure that number is being maintained. And that means that we should have the capacity to continue to run the elective work. As Claire said, we've been running models in relation to the impact of the Grange, I think nearly on a daily basis, with assumptions from Iron Bevan in terms of where they see their flows moving to the Grange from the North Gwent area, but also equally where the South Powys flows will be going. It's interesting that even over the course of the last few days, a revised set of assumptions reduces the bed requirement. And there are some very significant clinical discussions ongoing between our consultants in PCH and those within Neville Hall, and also our consultant clinical body in PCH with colleagues in Powys around how we may improve the flow back to Powys. A good example being people who come in for emergency care, say from Brecon into PCH, often ending up in a bed in PCH longer than you might want. Improving that discharge to recovery and assess process back to Brecon War Memorial Hospital with some outreach from PCH using some of our acute physicians will speed up and reduce the length of stay. So I know that sounds an awful lot of operational detail, Marcus, but there's a lot of thinking going on around it. That doesn't take away from the fact that this is going to be a challenge. So there's a very good set of assumptions. We've never had such good modelling. I wish, in years gone by, we'd had this level of modelling, because I think we would have probably done a better job. This has got a very integrated workforce finance and service plan, but it is a plan. And I think what we have to do is on a day and daily basis is kind of interact our lived experience into that modelling to see, so what's that doing? So if we take a snapshot today, what does the plan look like? Should have been where are we actually at, and how far adrift are we from that, and how we manage that. Sometimes we'll be up, sometimes we'll be down. If we're in the trajectory, that's great. If we're not, what other actions are we taking to minimise that down?
Alan, thanks very much. And just before I bring in other colleagues, can you just pull out for us? So Claire, as you quite rightly said, those assumptions about waiting times are to do with the most urgent patients. What can people who are waiting for a hernia operation, or something that we wouldn't classify as urgent, what can they expect in terms of their waiting times over the winter? Are they going to get worse, do we think?
Yes. I mean, the honest answer to that, Marcus, is yes. What I do think is that we need to, and I referenced it a little bit in what I was saying, is that exploring some of the other potentials. So we've just had a call, myself, Paul and Nick, around other capacity. I use the Powys example as a good one. So there are theatres there's a theatre in Brecon, there's a theatre in Llandrindod North Wales. We have our surgeons do some activity there. Could they do more? Could they actually be doing more work there for some of those routine day case operations? Now, I think, and what this all comes back to then, Chair, is the availability of the workforce. So if we've got a very significant outbreak, we've got a significant need, or we've got a significant numbers of COVID patients in our ITUs. That takes away the ability of our anaesthetists to be able to be off-site, for example. That reduces the level of our anaesthetists to be able to available to do work in the Vale. So it's a very tricky balance between, if you get a significant number of particularly ITU type cases, that can take away from the ability of those individuals to support surgeons to carry on doing either elective or routine work. You know, so again, I think we have to keep the board sighted in relation to those choices that we'll have to continually make in a very dynamic way over the coming days, weeks and months of the winter and into 21-22. This is not going to be something that all of a sudden becomes easy in 21-22, and some of the thinking that we need to put in terms of longer term planning now, such that we've got a more robust delivery mechanism for 21-22 and onwards.
Alan, thanks. That's very helpful. Colleagues, I'm looking at the chat bar for people to indicate if they've got a question. So if you have, please indicate there. And first of all, we come to Paul Griffiths.
Thank you, Chair. Good morning, Claire. Good morning, Alan. My question actually is very similar to the last couple of questions the Chair has asked, but I'd like to come at it from a slightly different perspective, if I may, particularly with COVID in mind. I presume that delivery of the Q3 and Q4 plan is to a large extent conditional upon the COVID numbers being kept under some semblance of control. If COVID numbers continue to deteriorate as they have done over the last few weeks, could you provide some indication of those parts of the plan which are most at risk of being put on hold, and perhaps just as importantly, those which will only be stopped as an absolute last resort?
So, if I was Paul, I think for me, I think the bit that we have a choice around is the elective programme. So without a shadow of a doubt, if the COVID numbers, again against that table you see on page 8, if we started to see a figure, let's take January 2021, rather than 168, it's 268. The question we then got is, have we got other capacity we could open elsewhere? So further work in the field hospitals, or further, you know, what is in essence. If it's in one hospital rather than in all three, can we move stuff around? Can we move work around between the three hospitals to do a little bit of what we did over the last 2 weeks in terms of movement of unscheduled care, even between hospitals, in terms of diversions and changes of boundaries? But that would be one of the areas we'd have to look at as elective programme. The urgent cancer care, as I probably alluded to in answer a couple of minutes ago, really, that is absolutely maintained on a risk assessed basis as an absolute priority. So in PCH this week and in POW this week, who have been under immense pressure in terms of ambulance delays at the front door and so on and so forth, they have continued on a risk assessed basis to provide urgent cancer care, other than where it was more risky for the patient to be in hospital than not. Does that kind of help give an outline of where we're at, Paul?
Yes, thanks, Alan. That's helpful.
Thanks, Paul. And we come next to Ian Wells.
Hello, thanks Marcus, thanks Alan and Claire as well. Can you hear me, by the way? Yeah. Yep. I think in the grand scheme of things, the things we're talking about, what I'm going to say might sound a little bit trivial, but I think really it's the way of working in the future. I think there's a few things in the plan which I think need to be commended, and I'd give some examples of those. I think quite often when people go into a crisis, they quite often think innovatively in terms of new ways of working and ways of going forward and so on. And there's a couple of examples, I think, in the plan which really are I think really something we need to highlight, which are excellent and will in the end reduce the stress and the workload on our staff and our systems in the future. And the first thing is the inclusion in the whole systems pathways discussion, and a particular example was heart failure and acute coronary, where we were talking about patient-reported measures being included within the systems that we use. Doctor being an example of that. That in the end is going to add a huge amount of information to our clinical staff to help them come to conclusions much quicker. And I think that we see that happening right across the health system, not just in our health board area, where there's a big movement now to bring patient created data or patient generated data into systems to help the clinicians make solutions. I'm glad to see that we are starting to look at that area. One thing to maybe ponder on that is that when we do allow patient included information or patient included data, how do we measure the quality of that? You know, is that medical grade data, or is that sort of hearsay almost data? And that's something maybe we need to think about. There's another example there as well, in terms of once again a crisis creating innovation and new ways of working. And I'm glad to see a section there talking about agile, flexible use of digital and so on, to improve the ways that we work in. And one of the examples that was included there was the Attend Anywhere, allowing our patients to sort of do video consultations, which I think is starting to take a big burden in terms of workload of our clinical staff. And I think we're going to see a lot more of that in the future. And once again, I'm glad to see that appearing in our future plans going forward. So more comment rather than a question, really. Okay, thanks everyone.
If I could just, I mean, Ian, I think that's absolutely right. It's fair to say that I think we would have been on a 2-year trajectory or more around Attend Anywhere without the pandemic. We deployed it across general practice within weeks, which was, you know, truly phenomenal, along with a number of other health boards. So you're right, crises do definitely push forward some of those easy win things that sometimes will take quite a long time to do. And I think if you ask general practitioners now how they feel around some of these things, the answer is overwhelmingly they welcome them. What they would say is it doesn't actually free up time. It's just a different way of doing things. It's, you know, and probably very right for patients. Some of the patient stories we hear, heard one fairly recently from the Drug and Alcohol Service. You know, people of working age able to use Attend Anywhere with the Drug and Alcohol Service, not having to go into a clinic. The issues about going into a clinic and being seen in a clinic and so on and so forth. So Attend Anywhere for them has been a fantastic innovation. They'll be able to maintain their job, maintain their privacy and dignity, and get their consultation done at a time of their choosing. So there are some really good patient stories and around this which we need to add into it, because it has been a good innovation. Thanks, Alan. Alan, you might want to stop clicking your pen. It comes across comes across rather loud on the mic. Thanks very much, Ian. They're very helpful points. Maria, we'll come to you next.
Thank you, Chair. Just one question for me, and it's around, this is a very, very ambitious plan for Q3, Q4, knowing the position that we're in with COVID and trying to deal with the winter pressures and all the unscheduled care work that we have to face over the next couple of months. My question is around regional working, around some of the issues that we're going to have to face. Have those discussions taken place? And if so, are there any plans in place for any working together on some of the issues that we're going to have to face?
Yeah, so Maria, there are a number of examples where we have been working regionally, and I guess there's always a couple of definitions of region, aren't they? So I qualify, there's the NHS regional conversations around supporting particularly elective and essential services, and then obviously there's the region in terms of a more regional partnership board type region. So if I just respond really quickly to the first one, you will see some aspects in our plan, for example, that we continue to work with Swansea Bay to make sure that both ourselves and Swansea Bay have appropriate access to the Neath Port Talbot site and use that as a green facility to the benefit of both of our residents. And I think Alan has already touched on some of the areas that we're exploring with South Powys around Brecon in particular. There is always more that can be done. And the challenge, I suppose, is that every organisation needs to be ready and have an understanding of their own system to be able to then bring that to a collective conversation. And I think that the focus for Q1 and 2 has been just that, has been individual organisations really trying to understand the impact on their services, what they can and can't deliver. I think what we'll see in Q3 and 4 now is a lot more regional working and a lot more regional conversations in a more focused way, because organisations understand their business now in this COVID environment in a way that they didn't and weren't able to earlier on. Just by way of example, there is a senior meeting next week for ourselves, Cardiff and Vale and an Aneurin Bevan Health Board, to have just this conversation. What more can we be doing? What more could we do on endoscopy? What more could we do around some of our wider diagnostics, around our wider elective programmes? So those conversations are well underway.
I'd probably just add, it comes down to the willingness of organisations. So I think if we went back to the beginning of the summer, Maria, the conversations around Neathport Talbot were quite frosty. But with a willingness and a push from the executive teams in Swansea Bay and in CTM, actually the operational teams across the piece actually have come together with a very good plan that was implemented from the 5th of September. I had little confidence in August that we were going to get to a particularly good position. By a month on, actually they were delivering 5 lists a day. Now, you know, as Claire said, there are issues around Neathport Talbot in relation to the furtherance of that being part of the COVID plan for Swansea Bay. But I think now, as we move into Q3, Q4, there's much more of a recognition between health boards of a need for that, you know, that mutual aid and working together piece, as opposed to trying to understand what's within their boundaries. It definitely feels like we've moved a step change forward around that.
Yeah, I think we need that, don't we, if we're going to deal with the demand and the elective work that we're going to have to be dealing with. Thank you for that. Thank you, Chair.
Thanks, Maria. Nicola, we come to you next. Nicola Milligan.
Thank you very much, Chair. Thank you both. Just picking up, and we know the amount of vacancies we have in the Health Board at the moment, but just can somebody give me a bit of clarity on Appendix 3 on the workforce plan? For September, the actual vacancies are 357, but then they drop to 40, 48 and 46. I'm just wondering why there's such a huge drop. Are we got a lot of staff coming from somewhere?
As you would expect, Nicola, I'm going to draw in Howell at this point. Sorry, Howell, but I did say it was going to be a breadth of executive input for this paper. So yeah, really welcome Howell's input on this.
Thanks, Claire. So the way the plan is constructed, can you hear me, Nicola?
Yes.
Right. So the way the plan is constructed, obviously we have to reflect all of the additional bits of supply that we bring in whole-time equivalent. So that includes bank, agency, healthcare support workers that we are bringing in by way of pipeline. So essentially the way our mitigation of the gap in terms of staffing is reflected is in the whole-time equivalent numbers. That's not to say we're expecting a barrage of 300 plus nurses. It's more that we will attempt to plug the gap in terms of demand for staffing and the conversion of full-time equivalents for what we think we can achieve through bank, agency and indeed increasing supply via overseas nurses, and all of our other bits of pipeline is reflected in that way in terms of full-time equivalents.
So are we saying, Howell, that we hope in October, November, December that we will fill an extra 300 whole-time equivalents from September? Yes,
so through those measures I mentioned, as well as potential for additional hours from our staff, etc., we are hoping, and it is our plan, that we will be able to fill those hours through the means that I mentioned earlier.
Thanks, Howell. You share my hopes too. Thank you. Thank you, Chair.
Thanks, Nicola. That was very timely, really, because the human resources, the staff in this are absolutely critical, aren't they, as everybody has pointed out already. How, in terms of our ability to bring new people into the workforce, as opposed to all the other measures which are described about, you know, overtime, etc. There was a big thrust, wasn't there, early on in the first round, to sort of recruit retired doctors and all of that sort of thing, to actually just to grow the workforce. Has that delivered much? Has it got further to run? What's your take on all of that?
So the honest answer is it hasn't. And there's a couple of reasons for that, I think. So you know, bringing people back in terms of retirement throughout the whole course of the pandemic since March has given us very, very limited numbers, so very small numbers indeed. It's a tricky area because, of course, there is an increased risk for certain elements of the population in terms of COVID risk, and age is one of those factors. So we also have to consider, you know, part of people's inclination to do that or otherwise, and indeed the safety of that as an option will have played a part in that, I think. Where we've had most success is twofold. One is increasing the size of our bank. So our bank has grown exponentially since March. I think we had just over 1,000 people on our bank in March. We've got just over 2,000 people now on our bank, and that's through a huge amount of work from my team, led by Donna Hill in bringing in additional staff to support our bank. And also we're now part of the collaborative bank project with Swansea Bay, which gives us the ability to flex across with Swansea Bay colleagues. The second area in which we've had some success is around our unregistered workforce. So HCAs, we do find it much more straightforward in this health board area to recruit HCAs than we do registered staff, so registered nurses in particular. So we know that nursing is a shortage profession across the UK. There are 40,000 nursing vacancies across the NHS in England. So we are at the same time attempting to bring in nurses from overseas, and we've recruited over 100 nurses from overseas since March thus far, with a further approximately 150 hope to come in by the end of March. But as I said, the main pipelines that have been successful for us are increasing the size of our unregistered bank and bringing in fixed term HCAs to support our establishments.
Thanks, Hal. That's encouraging, really, isn't it? In the face of all of this, to actually expand the workforce is a real achievement, I think, and vitally important for resilience. Alan, I know that you need to go and chair the Silver Command meeting in a minute, and I also want to just bring in Steve Webster just to talk about the financial elements of all this as well. But Alan, was there anything you wanted to say before you have to duck out?
No, I think I've probably talked long enough, Marcus. So unless there's any other questions, I'm happy to take a question in the next couple of minutes, but I will have to duck out of that part just now.
Thanks, Alan. That's great. And then Steve, so the resources to enable all of this, really, we've talked about the staff resources, and then finance obviously is another key element of all of this. Do you want just, Steve, just to pull out the key issues from your perspective in the plan?
Yeah, just very briefly, as part of the lead up to doing this Q3/4 plan, we had guidance from the Welsh Government, which included the additional allocations they are making into health boards to support Q3 and Q4. So those are very significant. They're outlined in the paper, but very broadly, there's a formula allocation out to all health boards, of which we are getting just over 56 million. Then there's funding for the various programmes such as TTP. Then there's some additional funding that we don't know exactly what we've got, but we will know broadly for urgent and emergency care. And finally, there's some partnership funding. So taken together, that funding is very, very significant. We've utilised that funding in the plan to support the activities in the plan, really. So, you know, Alan was referring to a lot of the key numbers. So the winter plans, which are, you know, as he was saying, at a very high level compared to previous years in the circumstances that we're in, to finance the workforce needed to staff the additional beds that we think we need to have open, depending on the height of the second peak. To staff the other elements of the COVID response, medical rotas, etc. etc. And then where we can to put money into plan care backlogs, and that's not a massive number in the plan, but that's really not around financial limitations. It's more around limitations in the options available to us around treating backlog plan care patients. So it's an integrated plan, and the financial bit of it is, is reflecting the service changes and the workforce changes, but we have got sufficient funding from the arrangements Welsh Government put in place to finance the plan. So it's a break-even plan.
Thanks, Steve. That's very good. Maybe just a moment just to pause and celebrate. The first time I remember a finance director saying that we've got enough money. I'm sure there are some caveats that I've ignored there, Steve, but thank you. That's very helpful. And Howell, I think there were probably, the workforce is so important in all this, isn't it? Howell, did you want to just to come back and pull out any of the other key messages from that section of the integrated plan?
Yeah, sure. So just a couple of things. Thanks, Marcus. Just to touch on. So the workforce plan really is intended to try and address all of the areas of demand that we've got as part of our response to the pandemic, as well as obviously our normal winter activity as far as possible. So that includes things like some of the things Claire mentioned earlier, such as mass vaccination, test, trace, protect, our additional capacity across the sites, but also the field hospital, and what we refer to in the plan as increased abstractions. And what I mean by that is increases in things like normal sickness. So we are just about to go into the winter period, which is usually our most challenged for sickness absence in any event. Then, of course, on top of that, we have COVID sickness, which is an additional feature, and COVID-related absences, which might be things like, staff waiting for a test result, or staff who are self-isolating for a period of time, having been identified as a contact, for example. So that all presents a significant challenge to us. And as I mentioned in my comment to Nicola earlier, our plan then, and as Alan quite rightly mentioned, this is a plan. The reality may and very well will be different to the plan, and our task there, and we're already experiencing that, is to monitor the plan and monitor the progress, particularly in relation to workforce availability. So what the plan doesn't say is that we can absolutely guarantee that at every point we will have the workforce available to do exactly everything we need. We couldn't possibly say that, but it does mean with best efforts we have plans in place, and we will be agile in response to what we see in front of us. Pipeline then, as I mentioned, our main reliance is on overseas nurses intake, HCA intake and bank use, as well as agency where we need to. But there are a couple of other staged elements to the plan articulated within it, which go beyond that, and they are potential for increased hours working, notwithstanding the potential well-being considerations there, because as you mentioned earlier, Marcus, we're expecting an awful lot of our people at the moment, and we can only expect so much of them. Redeployment potentially of staff from other areas, and we would potentially in that scenario need to make some decisions about services in that context, as Alan alluded to earlier. And then, of course, as we go along, iterative workforce planning at ward level, and looking at the acuity of our wards and the ratios that we apply in terms of nursing on wards, which of course will be in line with requirements from professional body guidance and Chief Nursing Officer guidance from Welsh Government. So I just wanted to mention those couple of things in relation to the workforce plan itself. Just on the well-being front, we had a long conversation about this yesterday at People and Culture Committee, which was really useful conversation, but we have hugely stepped up our level of service in terms of availability of well-being support for our colleagues over the last 6 months. And as Claire mentioned, we've introduced a very well evidence-based 4-step model for psychological well-being, which has been put in place by our head of employee wellbeing, who's obviously a consultant clinical psychologist. So again, something we need to very much monitor and keep an eye on as we go throughout the winter period. But we've got better services and more availability of services for our colleagues in place at this point than we ever have had before. So we would hope that we would be able to support people as best we can throughout the period. Thanks, Marcus.
Hal, thank you very much. That's very helpful indeed. So I think, colleagues, we've seen, haven't we, as it's been described, a balanced plan, which is exactly what we need, that brings in all of the elements, but which I'm sure is fundamentally realistic. These are difficult and probably to get more challenging times in the next few months. And we are not operating in a fool's paradise. You know, we need to be absolutely looking these challenges square in the face. Colleagues, thank you. Paul Mears, I wanted to bring you, perhaps, Paul, in at the end, just to sort of summarise the situation as our new chief executive. Any issues you just wanted to highlight, Paul, before we end this agenda item? Thank you.
Thanks, Marcus. I mean, no, I think colleagues have done a very good job of giving a very comprehensive overview of the whole plan and also importantly the risks associated with it. I think, you know, the reality is we're working in an ever-changing environment where, you know, at the moment we've done a plan based on what we know at the moment, but as we well know, in this current environment we're in, things could look very different in a couple of weeks' time based on the current pattern of what we're seeing happening operationally. So I think what I would say is that, you know, we have a plan here which I think has been really carefully thought through. But I think the test of this now is to think about, you know, making sure that we do whatever we can do to deliver it, which I think is, you've heard a lot about already. I guess just going back to the earlier point about the waiting times and the elective side of things, I think there is something though about how, in the same way we've had to be quite honest about what our reality is for people who are waiting. I think we also have to publicly be quite honest with people, because I think we are starting to see an increasing number of letters back to us or complaints about people who are waiting, and I think understandably, you know, people who accepted delayed to treatment at the beginning of this pandemic are beginning to question, well, if we're going to be in this situation for a long time yet, how do we possibly get some of the more routine procedures done? I think it's going to be probably one of our biggest challenges. So I think there is something about being honest with ourselves, but also honest with our communities about the challenges that we're facing and what that means in a reality. Having said all of that, as Alan described, also not shying away from some of the opportunities to try and think a bit innovatively and differently about how we could try and do some of the elective work, working with colleagues in other health boards, working with our clinicians to think about that. So I think it's a plan that is very much caveated with a lot of conditions and what ifs, but I think given where we are at the moment and what we know at the moment, it is very much the best way I think we believe that we can deliver our obligations for the next 6 months. And I guess the other thing to say is probably, and to think through with colleagues on the board, is how we make sure that we sort of bring back regular updates about how things are going against the trajectories and the plans, because I think, you know, what we've got here is a state of play as what we think will happen. I think it's really important through our performance reporting and things at the board that we bring back a regular update as to how demand is coming through. In line, is it in line with where we thought it was? If not, why not? And what does that therefore mean if we need to readjust things as we go through the next 6 months?
Thanks, Paul. That's very helpful. So, colleagues, we are asked. The plan was submitted to the Welsh Government last week, but on the proviso, obviously, that the Health Board needs to approve it at its next meeting, which is now. So, colleagues, can I just ask, are we content to approve the framework, as it's called, actually, the operating framework, as it's been presented and as we've discussed? I'll just pause just in case anybody has any other points they want to raise at this point. But I notice in the chat bar that I think colleagues are content. Good. Okay. Thank you very much, Claire. Thank you to you, Alan, Howell, and all your colleagues and teams for the huge amount of work that has already gone into this, and that I know will be continuing on a daily basis. Thank you all very much. Colleagues, I'm going to suggest we just take a 5-minute break now, and we'll resume at 10:39. It is on my computer in 5 minutes. Thank you. Right, colleagues, thank you. Welcome back. Let's go back then in the agenda to the previous item, which is the other main item we've really got to discuss today, which of course is the COVID-19 update. And very happy to have with us Dr. Sarah Thomas, who is a consultant in public health medicine, who is standing in for Kelechi Noam on this occasion. Sarah, we've had the paper, which is very helpful, but inevitably under these circumstances, things move on a daily basis. Sarah, is there anything particularly that you want to draw our attention to, either in the paper or that has happened more recently? Over to you.
Diolch, Deirydd. Good morning and thank you, Chair. Yes, I do have a set of slides that I'd like to share with you this morning. These are slides that we've taken from a presentation to the Regional Oversight Group of Tuesday this week. But as you rightly say, this is a very fast-moving situation, and so we're having daily updates. So I'm supplementing the slides that were the weekly view with some that were current yesterday. I've, during the course of the morning, also had some further figures shared with me that I will also supplement as we go through. So I'll cover those main points in relation to the data, and then I'd like to finish off by perhaps sharing a few key points of how our TTP response and work streams are dealing with the challenges of COVID across Cwm Taf Morgannwg. Could I have the next slide, please? Okay, thanks very much. Okay, board members will be familiar with this dashboard presentation. I understand it was shared with you at the last public board meeting. It is essentially our overview of weekly status, current week compared to previous week. And there's a lot of detail in there, and obviously the text is very small, but clearly what your attention is drawn to, and what I'd like to point out is the extent of the red in this dashboard, which is clearly showing that these areas are in need of attention. So essentially what this is saying is that we are seeing a deteriorating position across Cwm Taf Morgannwg, indeed across the whole of Wales, but I'd like to focus on our Cwm Taf position. So what we're seeing in recent weeks and certainly in recent days is increasing case numbers, case incidents, and also an increase in positivity rates. We're currently in a position where we have 60 clusters that we are managing across Cwm Taf Morgannwg. These include hospitals. You'll be aware that there are 5 outbreak hospitals that are being managed at the moment. I'll say a little more about that later on in my presentation. We have 26 care homes that have clusters. One of the notable things there is that we're now seeing increasing cases amongst residents. And then the other I wanted to highlight, and particularly of concern because of the closed setting nature, are a number of cases that we have in HM Park Prison in Bridgend. So given those sort of general areas of concern, can I take you on to the next slide? Do you have the next slide, please? Thank you very much. Okay, this slide indicates the case distribution across the Cwm Taf Morgannwg area. It's what we call the built-up areas. So these are the more focused on the more densely populated areas across Cwm Taf Morgannwg, where we're particularly monitoring very closely. So you can see the general distribution, and there being some particular hotspots in areas around Abercynon, Mountain Ash, that you'll see just on the boundary between RCT and Merthyr Tydfil. Also some other areas highlighted here, the Garw Valley in Bridgend. Further clusters or number of cases in Pyle and Porthcawl also. So the important thing I wanted to draw your attention to here is the fact that we've superimposed on this map where our testing centres are. I don't know how well you can see it, but these are the mobile facilities that we are moving around according to where the greatest need is, i.e. the greatest number of cases. And this is reviewed regularly between the surveillance workstream and the testing workstream to ensure that we're putting the testing centres in the right places. So they are currently one in each of the local authority areas as a minimum. Okay, if I could take you on to the next slide then, please. Thank you. The slide you have here is data that was shared with us yesterday, which was dated up to the 27th of October. This shows the 7-day rolling incidence rate and shows that the cases per 100,000 were for Cwm Taf Morgannwg close on 400, and this was an increase on the previous 7 days. Data this morning is showing that the figures for Cwm Taf Morgannwg are over 400 cases per 100,000, so it's gone up further again today. So this clearly is concern. Can I go to the next slide, please? The next slide, hopefully. Thank you. This slide is showing the positivity, and you can see that that also has gone up from the same period last week, and indeed by today 1 in 4 of the individuals being tested in our test centres are now proving positive. It's over 25% across Cwm Taf Morgannwg. So clearly not a good picture there. Not detailed on the graph, the table, but I'd like to mention about the age ranges that we're seeing, particularly in today's data that I've just seen. We're actually seeing now sustained transmission across not just the areas but across the age ranges. So we're seeing cases in community from children through to the elderly, and of course that then is translating into hospital admissions and inpatients. So we're seeing a distribution across the age range, particularly in Merthyr Tydfil and Rhondda Cynon Taf. Could I have the next slide, please? Okay, this graph shows the Office of National Statistics death data, which is the validated data that we follow, but it does actually have a time lag in terms of the reporting via the system. But sadly, as you can see, we're starting now to have more COVID deaths appearing both within the community and hospital. As you can see that the peak that we had in the first wave, and we're starting to increase again now during this wave. Again, this is a picture that's been seen not just across Wales but across the UK. Could I have the next slide, please? Okay. The next slide, board members will be familiar with that this is what's reported on a weekly basis in relation to the outbreaks in the 5 hospitals that I mentioned earlier. So again, this is data as of the 26th that was reported in our statement on Tuesday of this week. See that the numbers are there, but what I really needed just to make you aware of that we are seeing a deterioration in the position across the hospitals, with the exception of Ysbyty Cwm Rhondda and Maesteg, which from a health protection perspective are deemed to be stable or improving. Can I have the next slide, please? Thank you. So if I could just perhaps bring together some key points in relation to the efforts of the TTP programme across Cwm Taf Morgannwg. If I take the contact tracing first, we have a contact tracing work stream that is primarily located in the local authority, with quite a large number now of contact tracers and advisors employed. They are, as are the local public health team who are doing the contact tracing for hospital staff, becoming increasingly burdened by these large numbers of cases. And so we are looking currently to reallocate that resource to focus on the increasing numbers of hospital staff that are becoming unwell with COVID and testing positive. And just to add that this is a pattern that's been seen across the public sector, that staff delivering frontline services are being affected. If I just say a bit more about the hospital staff situation, in addition to the diverting of capacity to focus on the setting, we also have a number of interventions that enable us to get, or rather we're bringing in earlier intervention to ensure that staff are self-isolating and are particularly acting on symptoms at the very first opportunity. So there's a lot of work going on to enhance the intelligence that we have, so that we can make sure that the systems, as they're reviewed, are meeting the particular challenges that we're facing. Another thing to share with board members is the work that we've been doing. Hywel mentioned earlier about work around support for staff. We've been doing quite a lot of work as well about supporting staff to comply with the 15-point plans that are in place across each of the hospitals, identifying any potential barriers and supporting them to deliver services safely. If I move on to the testing, I already made reference earlier and pointed out the mobile testing facilities. They, as I said, were the lead for testing works very closely with the surveillance lead to ensure that we optimising the location of these mobile testing units. So this can mean that the testing unit is sort of in a place for a short time, then moving on and perhaps returning to that area at a subsequent date. With regards to communication and engagement of community, we're doing a lot of work here, have been all along, but very difficult to maintain the sort of enthusiasm of our public. We're experiencing quite a bit of pushback on social media messaging, with some quite aggressive responses, quite honestly. But we're working the risk communication and community engagement work stream together with the Protect work stream to ensure that when people are being asked to self-isolate, that they can do so safely and that they're not having to compromise due to concerns due to financial constraints and pressures in relation to the employment. So we've last week launched a support and advice helpline that is bringing together the contact tracing support together with the support of third sector colleagues and other assets in the community that could help individuals experiencing difficulty in that self-isolation period. Just wanted to mention a few words about vaccination. That there was reference to that earlier, and I know in the last board meeting you will have received the vaccination plans. The update on that is that the recruitment of staff has progressed very well, and that the availability of the vaccine now we're working towards a January 2021 timeline. I think a topic on everybody's mind at the moment is, so what happens beyond the fire break? Just to assure members that this is something that's being discussed within our incident management team at the regional level, and we last week submitted our thoughts and suggestions to Welsh Government, and as we know, Welsh Government are actually considering that as we speak with some imminent announcements. but we're very clear that the message needs to be clear and simple, so that our population can understand and follow those measures. And that concludes my update, Chair. I'm happy to take any questions.
Sarah, thank you. Very sobering, a very difficult situation, and in some respects still deteriorating, which obviously gives everybody great cause for concern. You touched on public attitudes, which is clearly a key element of all this. And Dilys, I think Dilys, you wanted to just re-emphasise that point about public attitudes. Dilys, would you like to just say a few words?
Yes, thank you, Chair. Sorry, I hadn't turned my camera on then. I have noticed across social media there is a definite change in public perception and increasing challenge to the facts about COVID. Having recently lost a family member myself, I and my family know the reality of COVID, and it's becoming increasingly difficult to see the attitude in social media about how people are reacting to the current pandemic.
Thanks, Dilys. That's very. I mean, I probably that doesn't require any answer, really, Sarah, does it? That's a very good point. Yeah. A number of other colleagues are wanting to come in. Ian Wells, we come to you next.
Okay, hello. I've just got a couple of points. The first one is relating to when we get the vaccination programme, because I was looking at the plan that we had on in terms of vaccination. I was looking at the phase 3 delivery targets, and I think it's really absolutely right that all the key workers are the ones that get vaccinated first, like the hospital staff, care home workers and so on. But I wanted a specific point related to the phase 3 delivery target, which is when we get to the rest of the population, so to speak, once we've dealt with all the key workers. And what it doesn't mention is groups that have multiple comorbidities. And I know there's a lot of research being done across the world that people who show comorbidities tend to be far more at risk in terms of COVID. And I was wondering, have we taken that into consideration? Like I know NWIS, for example, have recently licensed, I think it's Oxford, either Oxford University or Cambridge. I think it's Oxford University's algorithm for detecting patients who have comorbidities within the data that we've got for all our patients. So are we planning to utilise that when we get to that phase 3 delivery?
Okay. Thank you for that question. Yes, people with comorbidities are most certainly included in the priority groups, both for the flu vaccination, but also for the COVID vaccination when that becomes available. So yes, I can reassure you of that. Well,
that's excellent. And sorry, Marcus, I had a follow-on question, but completely different, and it's related to the random testing of staff. I know we randomly test staff in the hospitals or whatever to detect maybe some that have picked up the virus and not showing symptoms or whatever. But I was just pondering this, and why are we just randomly testing staff? Why don't we test staff that are living in specific areas where there are high areas of COVID, or we're working in areas where there are clusters in the hospitals? Maybe part of our testing could be related to that. I don't know. You might be doing that already, but just a thought.
Again, thank you. A very good point. We have a screening approach or strategy as part of the testing strategy, which, as you correctly mentioned and rightly mentioned, it's being used randomly across the board, but it does also have provision for being escalated in particular areas of concern. And indeed, there's a meeting this afternoon just to refine that now in light of increasing cases with each of the integrated locality group directors and their teams. So yes, it is part of the strategy, but as you would imagine, we need to be constantly reviewing that strategy to ensure that we're on top of the intelligence and the management plan.
Excellent. One last comment or a question, really. Just like to commend everybody that's involved with contact tracing, really, because absolutely fantastic 24 and 48 hour figures in terms of tracking those people down. So I just commend everyone on that.
Thanks, Ian. That's very helpful. A number of colleagues wanting to come in. Maria, we'll come to you next.
Thank you, Sarah, and thank you for that comprehensive report. And can I just say that, you know, the team is doing some excellent work, and our, you know, a heartfelt thanks goes out to the teams that are working around COVID at this terrible, unprecedented times. Two questions for me. One was around the testing strategy. And I can see that the turnaround times have improved, looking at your stats. But I was just wondering where we were in Cwmtaf around the turnaround of the 4-hour results.
The when you say the 4-hour results, Maria, can you just?
Yes, there is some work going on, isn't there? And results have been turned around within 4 hours to try and improve us picking up on the population and where these clusters are. Have we introduced that in Cwmtaf?
The lead for testing is constantly reviewing the response at the laboratory level. What we're finding is that obviously we've got various options in terms of where the analysis is indicating whether they're Public Health Wales laboratories or whether they are the Lighthouse laboratories. And what we're finding is that the waiting times are sort of state of flux. So we are sort of moving our testing demand or capacity accordingly. So yes, that is being under review, and Elaine is leading that work.
Okay, so you will be bringing some more information back if we were to improve the turnaround times around the results, yeah? Yes,
I certainly, when we provide a further update, we can specifically look at the turnaround times if that would be something board members would like. I didn't go into that in specific detail today, but very happy to do that.
Well, I think it is important, you know, looking at the figures and the position that we're in and addressing the clusters and getting the, you know, the community infection rates down. So that would be helpful. Yeah. My second question is around transmission in hospitals. Obviously, you've eloquently put that, you know, hospitals reflects the you know, and the concerns that we've been hearing from you, and the challenges that you face within the hospital transmission and the concerns there. Have we any strategy or recommendations further than what we've been assured on as to how we're going to deal with this in the imminent future?
Do you mean specifically with regards to hospital staff?
Yes.
Yeah. Yes. Okay. Yes. As I sort of just give some very broad headlines there of the plan, but one is around improving the intelligence and the data that we have around where the staff cases are and where there are clusters and where there are patterns. So that's something that's been enhanced. We've also got measures, as I alluded to earlier, about the contact tracing capacity to ensure that when staff test positive, that they are being contacted immediately by contact tracers, as opposed to the delay that is being introduced by inadequate capacity then for that contact tracing programme. And also about making sure that staff are aware of the symptoms and that they are able to recognise those symptoms and to stay at home. There is always that sort of duty of care to patients and to fellow team members that will make people want to come into work, but it's about being very clear that in these times we need to ensure that the infection control is the major factor. And clearly also around ensuring that there's strong leadership at local level, so that staff are being sort of encouraged to do the right thing, and that we have strong systems in place that allow that to happen. So that's a bit of a snapshot then, Maria, of the kind of things that are going on. But perhaps if I could just say a bit more about the work we're doing on the behaviour change. We've been very much using behavioural science. So I don't know if you're familiar with the COM-B model approach, which is around opportunity, commitment, and focuses on barriers. And one of the things that there are things that are around physical environment and things such as that only become apparent as you're talking to staff. And so there's a big piece of work going on as well to ensure that we're aware of every little sort of potential barrier that could be put in place or could appear, and to put mitigation in place for that. So I could expand a lot further, and I'd be happy to do so outside of the meeting, Maria, but just so you've got a flavour of what's going on.
Thanks, Sarah. Thank you.
Thanks, Maria. Very helpful. And Phil White, we come to you next, Phil.
Thank you, Chair. Diolch yn fawr, Sarah. Thank you very much. I'd like just to comment on the welcoming, if that's the word to use in these very strange, unprecedented times, that the improvement that we've seen in care homes, Sarah, and you know that working with them has kept those deaths down to a very minimum, or very minimum indeed over the last month or two, which is really welcoming. The only thing, and it's not a question really, maybe for another day, those figures wouldn't be distorted because maybe some of those care homes are not at the maximum like they were back in April and May. So I'm not sure. I need to maybe ask those questions in a different meeting. But what I'd like to ask, if I could, Chair, a little bit confusion for me around the immunity. And the test and treat, you know, what I'm hearing, Sarah, nationally and by a lot of so-called specialists, may I add as well, and experts, that the immunity rates are not as high as, or as long as they once thought. And if they are short, does that put the pressure on our test trace program, and especially around staff as well?
Thank you for that question. Yes, it's something, the question of immunity is indeed a question. You will, I'm sure, have heard in the media some reports recently that were published, Imperial College, I believe, that was indicating that immunity doesn't last as long as previously thought. That indeed is an area of concern. We really don't know the definitive answer on that one, but you're right, it is something that potentially, you know, we might have otherwise have taken comfort in the fact that if a staff member, for example, whether it's hospital or care home, had previously been infected and tested positive, that they would have then acquired immunity, which would have protected them going forward. With this recent evidence, clearly that is unknown as to whether that is true or not, and so that will undoubtedly put extra pressure and add to the complexity of the situation that we're dealing with.
Thanks, Phil. Emphasising again, not only is this a huge challenge, but we're dealing with a disease about which there are still so many unanswered questions, which simply makes the situation more difficult. Nicola, we'll come to you next. Nicola Milligan.
Thank you, Chair. Thank you, Sarah. That was a very sobering presentation, wasn't it? I just wanted to ask Sarah, I'm hearing that quite a few people now, when they attend a testing centre, are given a swab to take their own test. Have we got any information as to if this is successful, or are we having increased false positives or negatives, or is the evidence showing that this is effective?
Okay, thank you. Yes, as you point out, there are two ways of doing the swab. One is a self-taken swab, and the other is where a testing site member will do it for you. Clearly, it is really important that the test is undertaken properly, the swab is undertaken properly to ensure you're picking up an amount of the virus during the test. You've got that on the swab then to analyse it. we are aware of false negatives that arise, and that could be attributable to inaccurately undertaking the swab. I haven't got any figures to be able to sort of quote to you. There are sort of research papers ongoing about this, and certainly I could look into that offline to share with you, but I don't. It's not a statistic that we're capturing as an indicator per se, but it indeed is something that we have to be very mindful of, because we are aware anecdotally of people with classic symptoms who have tested negative.
Thank you, Sarah. I would assume, though, that if there's an issue, you would be re-swabbing and somebody would actually take the swab off whoever was displaying symptoms then.
Obviously, there is an issue here, but you need to be testing ideally within 5 days of symptom onset to ensure you capture that virus particle. You can shed those virus particles for several weeks after, so we will also get people who continue to test positive even though they are clinically well and are no longer infective. So again, it does add to the complexity of interpreting the results.
Thank you, Sarah. Thank you, Chair.
Thanks, Nicola. That's very, very useful, very helpful. Colleagues, I'm not aware of anybody else wanting to ask a question, in which case, Sarah, can I thank you for very, very helpful presentation. What a difficult situation this is, changing, well, probably by the hour, certainly every day, a situation we've never had to deal with before, and with a disease that we still don't know so much about. And with the cruelest possible consequences for those unfortunate enough to catch it and to catch it badly. So Sarah, thank you so much for that, and a big thank you to you, the team, and everybody else who's working on this. Thank you. Colleagues, we're asked to note the paper, which we do. Thank you very much. Right, colleagues. Remainder of the agenda, any other business is the next item. I'm not aware of anything. I'll just pause briefly if in case anybody has anything else they want to raise. No, in which case the date and time of the next meeting, the next formal public meeting, the next one of these will be in a month's time on the 26th of November. Colleagues, rwy'n dod a gyfarfod o bwrdd iechyd I ben, a hoffwn I ddiolch I bawb sydd wedi ymuno arni heddiw. Thank you, good colleagues. I bring the meeting to a close and would like to extend thanks to all those who have joined us today. Thank you very much.